Opacities in the cornea lead to decrease in visual acuity and quality of vision. In children, corneal opacities can be congenital or acquired. It is very important to restore clear visual access and early rehabilitation in children in order to avoid amblyopia. Full thickness penetrating keratoplasty in children is associated with numerous challenges requiring multiple examinations under anesthesia and long-term follow-up. Common complications of penetrating keratoplasty include graft infiltrate, increased intraocular pressure, cataract, endothelial failure, graft rejection, and delayed visual rehabilitation leading to amblyopia. In recent years, with the advent of newer and more refined techniques, anterior or deep anterior lamellar keratoplasty are re-emerging as a surgical treatment option in the management of anterior stromal pathologies with favorable outcomes compared with penetrating keratoplasty. Advantages of ALK over PK include less stringent criteria for donor tissue selection, advantages of being a completely extraocular procedure, absence of endothelial rejection, increased resistance to rupture of the globe after blunt trauma. Topical steroids can be discontinued earlier with ALK, and sutures can also be removed earlier with ALK, providing faster visual rehabilitation. Some of the indications for which ALK has been performed successfully include residual scar following pterygium surgery, corneal scar post-resolved microbial keratitis, corneal haze post-photorefractive keratectomy, Salzmann nodular dystrophy, anterior stromal dystrophies including lattice, granular, macular, and gelatinous droplet dystrophy. In this video, we will be discussing different methods of performing ALK along with an example of a case where manual ALK was performed with ease and complications associated with this procedure. Anterior lamellar keratoplasty can be performed either by manual dissection or microkeratome or using femtosecond laser. Microkeratome ALK, which can give promising results, has certain major limitations. The thickness of the tissue dissected by the microkeratome would depend on the speed of the pass as well as the amount of suction achieved. Both being variable factors can lead to graft-host discrepancy. This often results in the need to apply sutures, which offsets some of the advantage gained. The small selection of microkeratome heads also limits the choice for depth of the recipient bed. Femtosecond assisted ALK can provide extremely precise cuts and smooth interface in clear corneas. But in pathological corneas, the scar tissue poses challenges for laser penetration and a different refractive index as compared with the transparent corneal stroma. Compression by a flat applanating interface cones may lead to reproduction of irregular corneal surface at the interface. This 6-month-old boy presented to us with a corneal opacity involving the anterior third of the stroma after a resolved microbial keratitis in the right eye. In cases where the scar is too dense to allow adequate visualization of the pupil, marking the center is an essential prerequisite. A 7.5 mm Hasberg-Baron suction trephine is used for the initial partial trephination. One complete rotation was performed to achieve partial trephination of approximately 250 microns. Careful partial dissection using DORC dissectors is started along one of the edges in a forward sweeping movement. Difficulty at this point in holding the edge of the thin lamella may be experienced, and it is important to avoid formation of a buttonhole. The dissection is then carried forward and would require a more pronounced force for the sweeping action in the region of the scar. As the dissection proceeds forwards, we should ensure that the tissue is held down with the forceps to maintain the depth of dissection, as lifting of the tissue might cause the dissection to move in a more superficial plane. Once the entire dissection in the area of trephination has been completed, a curved scissors is used to excise the dissected lamellar margins at the edge of trephination. Care should be taken to avoid leaving any ledge of stromal tissue. The donor tissue is then mounted on an artificial anterior chamber. The same Hasberg-Barron suction trephine is used of the same size with the exact same number of turns to provide a lamella of similar size and thickness. The lamella is then subsequently dissected and cut using a similar technique as for the recipient tissue. It is very important to maintain adequate pressure in the chamber, which influences the depth of dissection. The recipient bed is kept dry using a Wexel sponge. Human fibrin adhesive glue of two-component mixture made of fibrinogen aprotinin concentrate and a thrombin calcium chloride preparation is reconstituted and applied as a uniform thin layer. The donor lamella is then placed over the host. The excess glue is ironed off, at the same time adjusting the orientation of the graft to ensure adequate edge-to-edge apposition. A bandaged contact lens is placed at the end of the procedure. On the first postoperative day, the child appeared comfortable. He was advised to use prednisolone acetate eye drops 8 times a day, ofloxacin 0.3% eye drops 4 times a day, and homatropin 2% eye drops 2 times a day. The bandaged contact lens was removed on the 10th postoperative day. There was no epithelial defect with good graft-host apposition. 6 months postoperatively, the child is maintaining a clear graft with an acceptable refractive correction. Despite being a simple procedure, it does come with its own host of challenges. Inability to achieve the correct plane during dissection of donor tissue can lead to buttonhole, which will require taking a new tissue, as a buttonhole can act as a source of epithelial ingrowth. Imperfect apposition at the graft-host junction can lead to epithelial ingrowth, as shown in this picture, where the cells have grown into the interface between the graft and the host, as evidenced in this anterior segment OCT picture. Rarely, failure of the anterior lamellar graft can also take place. This, however, can be easily contended with, as the anterior lamella can be peeled off with relative ease and can be replaced with a suitable tissue. This is easily a much simpler and easier procedure than having to do a regraft in a failed penetrating keratoplasty. Thus, this simple technique of sutureless anterior lamellar keratoplasty ensures an acceptable outcome without the attendant complications and risks of sutures as in penetrating keratoplasty.